Let's talk about some bone metastases. So this is usually going to be a patient that presents with aching pain that is worse at night. Sometimes they have worsening weight loss, but the really big clue on the NBMEs is pain that is worse at night. And so breast cancer can metastasize via osteoblastic or osteolytic lesions that you can see on your scan. The next best step, if you suspect breast cancer metastasis, is a bone scan or a PET, and that can progress with next getting a CT or MRI to further work it up. Osteoblastic lesions, you're thinking prostate cancer. And so you can consider a further workup if a patient has suspected prostate cancer and a PSA over 20. The other cancers that can cause osteoblastic lesions include Hodgkin lymphoma or small cell lung cancer. But the number one thing you should be thinking if you see osteoblastic on the USMLE is prostate cancer. That's the one that they test the most. But keep in mind, the exam gets harder every year. They start trying to put more and more tricks into there. So make sure you know Hodgkin lymphoma or small cell lung cancer as well. All right. And if you suspect that, what should you do? Next best step is to get a radionuclide, aka a radioisotope bone scan, and then get a CT or MRI for further differentiation. And so the treatment, if they have debilitating bone pain due to prostate metastasis, is radiation therapy. If you see osteolytic lesions, it can be a bunch of things. It can be multiple myeloma, it can be non-Hodgkin lymphoma, or non-small cell lung cancer. Keep in mind, remember, Hodgkin lymphoma or small cell lung cancer are going to be blastic. Non-Hodgkin or non-small cell lung cancer are going to be osteolytic. And so your next best step is to get an x-ray with a PET, and then to see further, you can get a CT or MRI. So that's kind of your algorithm for bone metastasis of cancers. Number 4, let's talk about medullary thyroid carcinoma. And so these patients will have an elevated calcitonin level. This is a huge clue for you. And this is due to the parafollicular C cells in the medullary thyroid carcinoma. Of course, they'll usually mention a neck mass in these patients as well. If the calcitonin remains elevated after you take out their thyroid, your next best step is to do a CT scan of the neck and chest to look for residual tumor. You don't want to miss this. So, patient gets a thyroidectomy due to a medullary thyroid carcinoma. They have an elevated calcitonin. Your next best step is to scan them to see if there's any tumor left over. If the CT scan is negative, next thing you should do is a CT abdomen as well as bone scan to look for metastasis. And something that's pretty low yield, but this is kind of the next step in the algorithm that they want you to know, is if you still have high suspicion for metastasis, but you have not seen anything yet, then you can progress to a PET scan or an octreotide scan. Number 5, this is mega high yield. So a 1 to 3 year old patient with truncal ataxia, opsoclonus myoclonus, irritability, developmental regression, and a painless adrenal mass that crosses midline with diastolic hypertension and sweating and flushing, you're thinking neuroblastoma is your diagnosis. The sweating and flushing is due to the catecholamines. It's a painless adrenal mass that crosses midline, and that's going to help differentiate it from a nephroblastoma, which does not cross midline. All right, and so for neuroblastomas, if you see them, a step 1 recap fact is it's an N-MYC gene amplification, and it's the most common adrenal mass. So if you're unsure if it's a young child that's 1 to 3 years old, they have an adrenal mass, your differential should include neuroblastoma at the very top. And so I've gotten test questions on this before where the baby seemed totally normal, had no developmental regression, they had no opsoclonus myoclonus, no jerking or anything like that, but they simply had sweating and flushing, a painless mass, and constipation actually due to bowel compression from the mass itself. And that's obviously a very advanced neuroblastoma that would cause constipation from bowel compression. And so some rare but testable features you need to know are back pain due to epidural invasion. It's called a dumbbell tumor, kind of forms this type of shape of a dumbbell. And it can also have periorbital ecchymoses, and that's due to orbital metastases. I've seen that tested actually, so make sure you know that. And so neuroblastoma is a 10 out of 10 high yield topic. Make sure you know everything that's bolded in red on this review point here. A key here that's kind of tricky and interesting as well is the diastolic hypertension that you see with neuroblastomas. You don't see diastolic hypertension, usually meaning a diastolic blood pressure that's over 100 or so. unless it's a neuroblastoma or it's renal artery stenosis. Those are really the two biggest things that cause diastolic hypertension on the USMLE. All right, number 6. If somebody has a recurrent abdominal mass, even after a hyper-aggressive surgery, they took a ton of lymph nodes, they took out a huge mass, one of the top things on your differential should be a desmoid tumor. And so oftentimes the questions will give you additional history than that. So they might say that the patient has supranumerary teeth, which would be Gardner syndrome. Gardner syndrome has the supranumerary teeth plus the desmoid tumors. Those are huge clues for Gardner syndrome. They also can have epidermoid cysts, which are nodules on the extremities instead of the abdomen. And so epidermoid cysts are seen with Gardner syndrome as well. If they say that there's a mass in the abdomen, you say it's a desmoid tumor in Gardner syndrome. If they say that there's a mass on the extremities in Gardner syndrome, you say it's an epidermoid cyst. So make sure that you know that. Those epidermoid cysts on the extremities generally resolve on their own, so you do not have to excise them. And I don't want you to get the epidermoid cyst confused with the dermatofibroma. And so these are also on extremities, but they're more of a firm hyperpigmented nodule that you see after a trauma or insect bite. So dermatofibroma is from some sort of traumatic insult, whereas an epidermoid cyst is spontaneous, and you'll see that with Gardner syndrome. So just make sure you have those terminologies separated. Dermatofibroma from trauma of some sort, epidermoid cyst with your Gardner syndrome. All right, and so if you're stuck and purely going off a location of the lesion in Gardner syndrome, if it's abdomen, your best bet is desmoid tumor. If it's extremity, your best bet is an epidermoid cyst. So hopefully that hammers in those high yield points for you. Number 7, again, another 10 out of 10 high yield topic. What abdominal mass that is often painful does not cross midline in the USMLE in a patient that is less than 5 years old? They also may have hematuria and hypertension. And your answer is a Wilms tumor, aka a nephroblastoma. And so I remember envisioning this as a tumor that was stuck inside the kidney in a very young patient that's 1 to 3 years old. And since it's stuck in the kidney, it's not going to cross midline. That was kind of the little scenario I created in my head to help me remember this. And so your treatment is going to be a nephrectomy plus chemo, and the management is to screen for recurrence with abdominal ultrasounds every 3 months. So you have to know the next best step is nephrectomy and chemo, and then after that, the next best step will be to continue screening for recurrence with an ultrasound every 3 months. So keep in mind, this nephroblastoma in the kidney is painful. The neuroblastoma in the adrenal is not painful. All right, number 8, multiple myeloma. Again, another 10 out of 10, highest yield topic. So you're going to diagnose this with an SPEP or a UPEP showing an M spike. The confirmatory test is going to be a bone marrow biopsy, and it's going to show over 10% plasma cells. Okay, so your next best step in this instance is a whole body low dose CT or MRI or PET scan to evaluate the osteolytic lesions that were seen on the previous x-ray. And so the trick question here is to not select a DEXA scan. This is used for osteoporosis, not multiple myeloma. I actually fell for this on a practice question at one point. They said, how do you further evaluate these lesions seen on an x-ray? I thought it was a DEXA scan, but it's not. So make sure you learn from my mistake and know that the best answer is going to be a whole body low dose CT, but they can also list an MRI or PET scan as well. All right, so next I want you to be cognizant of hyperviscosity syndrome due to the IgM pentamers that are associated with multiple myeloma. They're more commonly seen with Waldenstrom macroglobulinemia though. So I think of an M shaped like this, and upside down it's a W, and so that's how I remember that the IgM pentamers are associated with Waldenstrom macroglobulinemia. And so if you have Waldenstrom macroglobulinemia, they oftentimes will have blurry vision, oral bleeding, and sometimes even confusion. And so your treatment for that severe instance is going to be plasmapheresis. Okay, and so it's important to note that plasmapheresis is also used for conditions like TTP, myasthenia gravis, and Guillain-Barré syndrome to remove the circulating autoantibodies. Multiple myeloma and Waldenstrom can also be associated with type 1 cryoglobulinemia. And so let's kind of talk about the cryoglobulинemias. This is a little bit lower yield, but it is still tested from time to time. And so type 1 cryoglobulinemia is associated with the plasma cell dyscrasias, meaning multiple myeloma and Waldenstrom macroglobulinemia. The cryoprecipitates are going to cause vascular occlusions, so you'll get livedo reticularis, which is that lacy coloration of the skin. Oftentimes it's on the lower extremities. You'll also get digital ischemia. And the symptoms of hyperviscosity can include blurry vision, vertigo, and ataxia. To diagnose type 1 cryoglobulinemia, these patients are going to have a positive cryocrit with normal complement, as well as an elevated ESR and a positive monoclonal spike on SPEP. And that's easy to remember because it's associated with multiple myeloma and Waldenstrom's macroglobulinemia. So you use an SPEP to help diagnose multiple myeloma, and you also see a monoclonal spike on SPEP with type 1 cryoglobulinemia. And so the treatment is to treat the underlying disorder. So you treat the multiple myeloma or the Waldenstrom's, and you can use plasmapheresis to remove the cryoglobulins if they have severe hyperviscosity. So if they have any of these symptoms of the vascular occlusion, the hyperviscosity, blurry vision, vertigo, ataxia, those types of things, you want to use plasmapheresis to remove the cryoglobulins. And just as a recap here, the treatment of multiple myeloma, there's multiple algorithms, no pun intended, but be familiar with the medication bortezomib. It's a proteasome inhibitor. I've seen questions on this multiple years. There's also melphalan or lenalidomide as well as options. And with multiple myeloma, you want to be sure to start them on a bisphosphonate. All right, for Waldenstrom macroglobulinemia, the treatment here is the plasmapheresis if they have the cryoglobulins causing severe viscosity, or you can also use rituximab, which is a CD20 inhibitor to stop the plasma cells from basically proliferating with this plasma cell dyscrasia. Let's talk about type 2 and type 3 cryoglobulinemia. These are going to be associated with HCV, HBV, as well as HIV, as well as some of the autoimmune conditions such as lupus or Sjogren's disorder. And this is due to IgM-RF rheumatoid factor that's bound to a polyclonal IgG. And these patients get vasculitis type symptoms. So they'll get palpable purpura, glomerular nephropathy, arthralgias, neuropathy, and hepatomegaly if it's due to hepatitis. These patients, to diagnose them, they'll of course have a positive cryocrit, just like the type 1 cryoglobulinemia. They'll have low complement, such as low C4 levels. This is different than type 1 cryoglobulinemia. Let's scroll up. So type 1, remember they have normal complement. So if you see somebody with multiple myeloma or Waldenstrom's, they're going to have normal complement even if they have cryoglobulinemia. On the other hand, if you see a hepatitis or an HIV that has a positive cryoglobulinemia, these patients will have low complement. So keep that in mind. They'll also have a positive rheumatoid factor, just like the type 1 cryoglobulinemia, and they can even have positive antibodies as well as ANA, and that's easy to remember because it's associated with the autoimmune conditions like Sjogren's as well as lupus. So most important thing to differentiate in your head between type 1 versus type 2 and type 3 cryoglobulinemia is the complement levels. Type 1 is normal, type 2 and type 3 have low complement. All right, talking about hepatitis, let's kind of go along this track here. So Hep B plus or minus Hep C, as well as a triad of palpable purpura, arthralgia, weakness or neuropathy. Your diagnosis is going to be mixed cryoglobulinemia. So look for that low C4 level, the low complement like we just talked about with type 2 and type 3 cryoglobulinemia. Look for a positive rheumatoid factor, as well as look for hyperviscosity. And so both cryoglobulinemias can get hyperviscosity, but type 1 is more associated with it. So if you see the blurry vision, the ataxia, the confusion, those types of symptoms, it's more likely to be a type 1 cryoglobulinemia, but there is some carryover between three. All right, and so it's important to note that there are no GI symptoms with mixed cryoglobulinemia, and this can help you separate it in your mind from Henoch-Schönlein purpura, which also can have that palpable purpura. It can also have some of the joint and knee issues that you would see with the mixed cryoglobulinemia. So if there's no GI symptoms, that should point you more towards the Hep B, Hep C triad that makes up mixed cryoglobulinemia. And so your treatment here is going to be to treat the hepatitis as well as pulse dose prednisone or plasmapheresis if very severe symptoms.